Let's talk about the pancreas. Normal anatomy. Remember, just stick to normal and you're going to get used to what normal looks like so you can pick out abnormal. Some reminders of the anatomy. The gallbladder is right lateral to the pancreas over in the liver. So just imagine your liver in this area here. This is a nice drawing to show you how the common bile duct courses through the posterior lateral aspect of the pancreas head. This is the neck uncinate. Remember, this does go posterior in the body. It's just kind of hard to draw it that way. But your CBD connects with this main pancreatic duct, and then it enters the duodenum at the ampulla levator, controlled by the sphincter of Oddi. Okay, so you'll need to know that for the pancreas as well. You can see the pancreas has a lobulated gland, and it doesn't stand out very well in the body because it is not encapsulated. Some embryology about the pancreas. The primitive pancreas, so in utero, has a dorsal and a ventral bud. Dorsal bud is a diverticulum of the duodenum. So diverticulum means an outpouching of a hollow or fluid-filled structure in the body. So the dorsal bud is part of the duodenum, and the ventral bud is a diverticulum of the CBD. At 6 weeks, this ventral bud rotates, okay? So here's a ventral pancreas off the CBD and the dorsal bud off the duodenum. The ventral bud rotates 270 degrees and changes position, comes posterior in this rotation, and they actually fuse to become the pancreas. And just think the body is amazing that it comes from here, rotates, and fuses to become an organ. The ventral duct in the head anastomoses with the proximal dorsal duct to form the main pancreatic duct. There is a Wirsung's duct in 60% of adults, and it drains into the CBD. Okay. So the Wirsung's duct is the pancreatic duct. And then there's the ventral duct, which is called Santorini's duct. It usually disappears, and we don't normally see it here. But if it is still present, it is an accessory duct. It's just there to help a little bit. It does not have the main function as the pancreatic duct. So you're going to want to know the accessory duct of the pancreas is Santorini's duct, and the main pancreatic duct is called Wirsung's duct. And we learn about the main pancreatic duct connecting with the CBD, and it does this in 60% of adults. This is just the way we learn it. It can be hard to follow. You won't see this connection in most people, but if it's dilated, you might see it. So you need to know your anatomy and looking at the pancreas and all of these gastrointestinal relationships, which make the pancreas harder to visualize. But as you've seen in class, you can find the pancreas. You just have to know your landmarks. Okay. So we have the fundus of the stomach is superior to the pancreatic tail, and the pancreatic tail, remember, is the most superior part of the organ. The body of the stomach is anterior to the tail and the fundus, so it just sits right over this. And some of you have tried the water, and that's why drinking the water can create the cystic window for you to see this pancreas. The pylorus, this is where the stomach meets the duodenum. It's anterior to the neck and body, and the head sits in the C loop of the duodenum, so all this bowel. And then the superior duodenum is anterior to the neck and superior to the head. Then you have here is the transverse colon. So that can be a hindrance as well, depending on the body habitus. Everybody's different and what's going on in that transverse colon. So there's a lot going on around this pancreas, but you can see it if you just try. The descending colon, second part of it, lies lateral to the head. The horizontal duodenum lies inferior to the head. These are just the different segments. We just really will say the C loop, but you have studied the bowel before, and you'll study the bowel again. And then I just mentioned that transverse colon. The pancreas can be in many different shapes. It does have the head, neck, body, and tail. You can notice in these they don't really draw the uncinate, but it can be a tadpole shape, this dumbbell. We've seen a lot of different shapes, the teeny tiny bodies, a sausage shape, and you're not seeing the head wrap around, these going posterior, and then even this boomerang shape. It's it varies with every patient, but you'll have that splenic vein to help outline it for you. It is non-encapsulated. It is a retroperitoneal structure. There is a small portion of the head that does line the peritoneum. Also, remember it lies in the anterior pararenal space. We're going to talk about all the random spaces in the body in a different chapter, but the anterior, which means more more towards the front of the body, pararenal space near the kidneys. It's found in the epigastrium and the left hypochondrium because it extends over to the splenic hilum. Everybody's body's different, so whether you can see the spleen or not, it just depends. Remember, it lies obliquely with the tail being the more superior and your head being the most inferior portion of the pancreas. And then here is all that relational anatomy. But just remember, to find it, use that aorta and IVC, that SMA, because that body and the tail are near those organs. Vascular relationships, we've talked about. This is that tortuous splenic artery that is the superior border of the pancreas. So that means toward the head, superior. Okay. And then you did these with your pipe cleaners, remember, the gastroepiploic, but we just ask you to remember the largest ones. Okay. And then that splenic vein is going to be here. Here's the spleen. You can see the splenic vein of the hilum, but it runs in the middle of the pancreas. Posterior, and here's your main portal vein, and this is the SMV coursing medial to the head. So the head is lateral to this SMV. And then you have your neck, and your uncinate goes posterior to it. This is the common hepatic, which goes to the proper hepatic, and then I said it backwards, proper to common, but this is the GDA that is the anterior lateral circular structure you see in the head versus the posterior lateral circle that you see, which is the common bile duct. So here you can see again, we have this splenic vein, all right, and it connects with the SMV to form the portal vein, which goes up toward the liver. Here is that CBD in the posterior lateral aspect of the head. So look how this splenic vein joins. This is the confluence area. So you're going to see in your book, I've flipped through it, and sometimes it labels that area in the ultrasound images as the confluence. Sometimes it labels it as the splenic vein. If you're true transverse and seeing this, then it's going to be the confluence, because see how this is superior in the pancreas? But when you drop your thumb and you're getting the image with the circular structure here, then that's where it becomes the SMV. But they interchange it. Just know I want you to call it the SMV because that's what you're going to learn at clinical. Like I said, there's no point in arguing about it. It's interchanged in all kinds of textbooks. But know what I've told you. The normal length of the pancreas is 15 centimeters. We don't measure the length of the pancreas because it's not as straight, and the length just isn't something that we worry about. It can range from 12 to 18 centimeters, and in children, it's actually larger and thicker, and it decreases in size, sorry about that, with age, and it also gets more echogenic with age. Okay, so we know with kids it's just thicker and larger, and it gets more echogenic with age because the fat forms within the lobules. So here's the pancreas tissue here, that nice splenic vein outlining it for us, and that SMV. So see the liver, and then here we have the pancreas here, okay, all the way here. They're actually measuring the thickness, not the length, but the thickness. If you do measure something in the pancreas, you're going to measure the head, and we've stopped even teaching that because nobody measures it. But if you're measuring anterior and posterior, you're just going to measure the head right here, anterior to posterior. And I will find a slide and measure that for you. If you look really close, there's your GDA. Here is your CBD. Not seeing it really well on this image. So the head, we already said, is the most inferior portion. It is to the right of the SMV confluence. It sits in that duodenum, which is, this is bowel gas here, the C loop. The IVC is posterior. Sometimes it's not just posterior. You might see it off to the side a little bit. The GDA, now this is one of those that sits really cockeyed, you want to say, but this is your GDA and this is the CBD. So we tell you, don't throw color on it for our protocol, just do the one that's posterior, but this can be hard to tell. So this is so big, if you throw color on it, it should take 2 seconds. If there's no color, then you know, just because they're sitting kind of wonky in this pancreas, to check it and make sure. The portal vein is superior, which is cephalid to the actual portal vein. So you would have to move your probe superior to see the portal vein. And the pancreas head, if you measured from this point to this point, should be less than 3 centimeters. Okay. And so when we say less than 3 centimeters, it is 3 centimeters would be within normal limits as well. Anterior to posterior, your head. So here's just a lot of drawings in here to help you see. The head sits in the C loop of the duodenum here. You have your gallbladder, your biliary apparatus joining with this main pancreatic duct. Okay. Then we have that uncinate process, which is the little piece that wraps around that SMV. These vary in size on everybody. It's anterior to the IVC, which we said the head was as well. Okay. And just where, I mean, like we said, this IVC can sit over here, 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 just different locations. And it is, the uncinate is posterior to your SMV. Posterior. Your neck, which is this portion, and we say that because you can just think of your long image, the hamburger sign, and this is going to be the little piece here and your little piece of uncinate. And the bun is the SMV. So that's how we know neck, uncinate. You know, we're not going to say where does the neck start and end. It's just anterior to the SMV. Your body is this whole area. We don't know, we don't have a certain point where the body ends and the tail begins, but it's anterior to your SMA, this area. Okay. Your anterior border, this right here, is the posterior wall of the antrum of the stomach. Okay. The right lateral border is your neck. Your splenic vein course is posterior. And the body is the largest portion, and this would be like the widest portion here is the body. Your tail begins to the left of the vertebral body here, vertebrae, to the left of the aorta in most patients, and it does extend posterior and to the left to the splenic hilum. I can't remember who we were scanning, but you saw their spleen so nicely over here, and we'll have to pay attention to that because if you see it, the spleen looks just like the liver, but it doesn't have as many vascular structures in it. And if you see it over here on the left side of your screen, that has to be the spleen. Check for the tail, because if you flipped your probe, then it's going to be not true. So let that splenic vein help you outline this pancreas tail. Remember, it's going posterior in the body, okay, toward the spine in transverse plane. The left kidney will be over here, so it's anterior to the left kidney, posterior to the stomach, and the spleen's here, so the pancreas tail is medial to the spleen. More vessels for you to study. There's plenty of diagrams in here for you to study. We talked about the duct of Wirsung, also known as that main pancreatic duct. It runs the entire length, transverse length of the gland. It does receive tributaries from all the lobules, and it joins that CVD in the pancreas head. Where it joins can vary. And 2 to 2.5 millimeters in the anterior posterior diameter is considered within normal limits. So just say 2.5. Remember, it's a duct, so you don't include the walls. And the actual caliber of this can change during an exam depending on what's going on with their digestion. So this is the main pancreatic duct right in the middle. You should see pancreas tissue on each side of the duct to be sure it's a duct and not a vessel, not mistaking it for the splenic vein or that serpiginous splenic artery. But when in doubt, if you're saying that's the main pancreatic duct, you should take a picture with color on it just to prove what you know what you're talking about. That secondary duct, also known as the duct of Santorini, it drains the upper anterior head and it is not usually seen. The CVD, you should know all about the CVD right now. Right? It's to the right of the proper hepatic artery, just to let you know these acronyms here. And just a refresher, because this is what we've said with the biliary system. I don't have to read that again to you. I will point out right there, there is the CVD right here. So remember your vascular relationships. The IVC is posterior to the head. Sorry, the splenic vein is posterior of the body and the tail. The superior mesenteric vein travels to the right of the SMA, and they are parallel, and ascends to the anteriorly to the third portion of the duodenum. Sorry, there's people in my house if you hear talking. So this is just it. Like I said, the SMV and the splenic vein join posterior to the neck to form the portal vein. But remember, the whole pancreas has dimension. So this is more superior in the pancreas. When your true transverse is where the confluence is, but it's okay. The portal vein ascends cephalid to the head of the pancreas toward the porta hepatis. And you see that when you're scanning long on the head, you can actually see it coursing over to the liver hilum. And then in transverse, when you are coming down true transverse, you actually see the portal vein and the pancreas tail. So practice these things. Try true transverse so you can see this portal vein really nicely. You'll see it completely elongated, and then when you drop your thumb, then you see the whole entire pancreas. And this is a nice image showing that splenic vein meeting with, this is the IMV, here's the SMV, where they meet, this is the confluence, and then the portal vein goes cephalid at a little oblique angle to the liver hilum. Here's the stomach, how it covers the pancreas. The aorta, these are the arteries now lie posterior to the body. The splenic artery is tortuous. It is the superior margin, and you know it comes off the celiac axis. And this will be superior on the actual transverse pancreas. You'd actually have to move your probe on the superior aspect of the pancreas and maybe see some circles that aren't connecting. And then in long, it will be on the superior aspect of the body and the tail. So if you see two circular structures or even elongated structures, the superior one is the splenic artery. And you know that SMA is your landmark. Splenic artery, tortuosity of it varies with patients. Okay, here's that common hepatic going into the proper, and then here's that GDA in the pancreas head. Here's that SMA coming off of the aorta here. So, a good reason that we start off with a vascular first is it's some really good landmarks for you to build upon and learn your anatomy. We've talked about the common hepatic artery and the GDA as well. Just more drawings for you to reiterate your studying. We can print these and color them if you need them, or you have your lecture printed, but just you have to know all this relational anatomy when you're talking about the pancreas. That celiac is superior. This means you'd actually have to move your probe superior to see that celiac trunk. This is a nice image. So we zoomed and we're cutting it off, but we're showing that GDA and our CBD. This is a transverse pancreas. Okay, you know it's transverse. Your aorta is round, your SMA is round, and you have that little raccoon sign here. So use those vessels to help you decide on the scan plane. And these are just different levels for you, just outlining and pointing out the highlights. So you see the liver here. I don't even know most. A lot of patients, that left lobe, inferior left lobe, is going to be a nice window to your pancreas. This can really help you. So if for some reason they have a small left lobe and the pancreas isn't, the liver isn't helping you, move your transducer a little bit superior into that liver and angle down through it if it's very close. If it's too far, you don't want to angle. You get the best images without an angle. But this has been, go back and look at all your liver scans and that inferior left lobe. Unless you zoom too much, you'll be able to see at least the pancreas, body, and head. If you did your depth a lot, you may not pick out the tail. But go back in all your aorta studies and your liver studies and pick out the pancreas for yourself. But remember to use that liver when you can. There's going to be the challenging patients where the liver doesn't help you, but just try. Okay, I'll point out here we have the CBD and our GDA. Got some fluid in the stomach right here. IVC posterior to the head. Aorta is posterior to the body. And here, this IVC is directly posterior, and then over here, it's a little bit to the right. There, believe it or not, are congenital anomalies with the pancreas. They are rare, but they do happen. We'll talk about agenesis, pancreas divisum, ectopic pancreas tissue, and annular pancreas. So agenesis is a congenital malformation in which either the entire dorsal pancreas or part of it fails to develop, and then agenesis means it didn't develop fully. Okay. Symptoms can be none. They can be hyperglycemic. They can have diabetes mellitus. That's what DM. They can have a bile duct obstruction, pain, or even it can lead to pancreatitis. So if they had something going on of these, they would maybe investigate further, and that's when it would be discovered. A pancreas divisum is rare, and this is where the buds didn't fuse correctly. And this can be difficult to identify sonographically because of all the bowel and everything going on in that area. And then we have, I'm so sorry, ectopic pancreatic tissue. And this is the most common anomaly. And these will be like little nodules in different places, usually in the gastrointestinal tract, the GI tract. This is not something that you're going to investigate or look for. It's something we'll be seeing on other imaging modalities. You just need to know that it can happen. And these little nodules can get acute pancreatitis in those tissues. Annular pancreas is a persistence of the dorsal and ventral pancreas. So maybe it didn't rotate all the way. And what happens is the head of the pancreas can encircle that duodenum. This is more common in males than females and can be associated with complete or partial atresia of the duodenum. So see this picture? So we have the pancreas and it actually wraps around the duodenum. This can be, if it squeezes really tight, it can cause a lot of problems. Okay, so this might be something they discover thinking it's pyloric stenosis when it's actually annular pancreas. The symptoms are nausea and vomiting, feeling full after you eat, and feeding problems in newborns. So this would, if it's loose, you may not know it, but when it starts squeezing, you can have these problems. And they actually have to do a surgical bypass of that obstruction segment of the duodenum. Okay. Here, they wouldn't do anything with the pancreas because the pancreas is a much more sensitive structure. Physiology of the pancreas, you have this in anatomy and physiology, and but you do need to read this and review it. It's an exocrine and an endocrine gland, okay? So it's got digestive functions and hormonal functions. Your pancreas is a very important gland. So when you study this, the acini are these sac-like clusters for your exocrine function. They produce that pancreatic juice that is with digestion. It empties through those ducts. The gland is a primarily exocrine gland. It performs the exocrine functions most often. 98% of the pancreas performs those. And this is just showing you the amylase and the lipase. Hopefully that you talked about those in anatomy and physiology, but they are in the textbook because it's important. These are the labs you're going to look for that are associated with pancreatic disease. Exocrine, so read those. The endocrine functions have to do with the islets of Langerhans, and these are the alpha, beta, and delta cells. The beta are the most prevalent, and they produce that insulin. So diabetics have issues with their pancreas. Alpha produce glucagon, a hormone that causes the cells to release glucose for energy. And then the delta cells produce somatostatin, which inhibits the production of both insulin and glucagon. So they all work together to keep things in balance. And that's what we mean. And wait till you hear, the pancreas controls a lot, and the thyroid does as well. So lab values for the pancreas, because you want to look these things up when you're at clinical. You want to ask, can we review the chart? Or while they're looking at it, can you show me what you're looking at? So serum amylase, which means in the blood, with inflammation, it's increased. With inflammation and acute pancreatitis, so your amylase will be 2 times the normal value. In chronic pancreatitis, it could be normal. There are other conditions that can cause an increase in serum amylase as well, and intestinal obstruction and mumps. So it could be other things, but what you're doing with ultrasound with the pancreas is looking at, is it normal looking tissue? Is it abnormal looking tissue? You're not going to really be able to get specific unless you see masses. Ultrasound cannot test function of organs. So that's amylase, and then increased lipase in acute pancreatitis and in carcinoma of the pancreas. And this is something to remember, that the lipase, increased lipase levels will persist longer than the amylase. So depending on when you patient had their blood work, amylase could go back to normal, but lipase will still be elevated in acute pancreatitis. So they can have increased levels of glucose with severe diabetes, chronic liver disease, overactive endocrine glands, and tumor of cells of islets of Langerhans labs. So sonographic technique and appearance, you've seen this, but you want to compare it to the liver. And you never just do a pancreas. It's going to be in a right upper quadrant study or an abdomen study. So, you don't have to take a liver pancreas image interface, but you will be able to see them. So your echogenicity settings are very important. So the pancreas should be isoechoic to hyperechoic to the liver. Okay, so iso or hyperechoic, and I mentioned earlier it gets more hyperechoic as more little fat fills in the lobules, and on kids it actually is hypoechoic to the liver. And this is what I just said about the surrounding fat and why the echogenicity increases. So here is an endematous pancreas. Okay, this one's if we didn't have these arrows, it might be really hard to make out, but we have our landmarks here, and that SMV and that splenic vein. So this is a really puffy, swollen pancreas, and you have to be careful because this looks like a mass right here. So they have to be fasting. Try, most patients we do supine. Sitting can be just raising the head of the bed, and that can really help push the gas down out of the way. I mentioned that most sites are only going to do transverse images, and then long, if they see an abnormality, you need to practice both because you are learning how to scan. Don't forget the pancreas is an oblique lie in the body with the tail most superior. So if you're scanning it and your transducer is not oblique, you more than likely do not have the entire organ. And how oblique is varies on every patient. Big breath in, poke your belly out, drink, many different things that you can try. Use the liver as a window in just different ways that we talked about. Landmarks are just listed here for you. This is a transverse image, and even though it is the long axis of the pancreas. So we're going to go just through the protocol for you. So here is this head. This is a more lateral head when you're seeing the CBD and the GDA, and it is a long image. We elongated these a little bit. So this is the tissue. There's that portal vein. So this is the lateral image you take with the CBD, and your portal vein will start moving toward the hilum, whereas this is the image you take with just the head, okay, with your portal vein touching the head, and you'll have your IVC posterior. Your neck, and this is really pixely, but it's just adjacent to the head. It's medial to the head, anterior to that SMV. This is a long image because we can see the long aorta, but here's that celiac and that SMA. And we said a lot of times that body will sit right in the crux of these two vessels, okay? And let the splenic vein be your guide, okay? The splenic artery just might be one of its tortuous stents in this image, and that's why you're not seeing it. But here's that SMA, okay, and the panc body is anterior to the SMA. Harmonics, this is with harmonics on that we've talked about, and it does things to your frequency that we'll talk about in physics, but you can see this image is a lot more detail than this image. This is water in the stomach. A lot of you tried that, and if you haven't tried it, make sure you do try it. I've always wanted to do a project where we try different things like yogurt in the stomach. What does that do? Water. What would soda do in the stomach to visualize the pancreas? So we need to remember to try that. That would be interesting. We could do a collection of images. There are contrast agents that would be good for seeing the tail of the pancreas, but they contrast and ultrasound is an upcoming field. Some sites are using it, some it's not FDA approved yet, so it's not used very frequently. So like I said, ultrasound is not the main imaging modality for the pancreas, but could be a first choice because we're inexpensive and there's no biological effects and no radiation. But you can see, oh, the gland looks normal or it doesn't look normal. But remember, that's not function. So radiography, this ERCP, endoscopic retrograde cholangiopancreaticoduodenography. Okay, ERCP, that's why we say it like that. CT and MRI. So these are talked about in your book a little bit for more detail, but they are more effective at diagnosing pancreatic disease, but that doesn't mean we can't be a partner with them. Your protocol is here for you that we've been through in detail. And then I have your images with landmarks and what the pancreas would look like, as we have done in other protocols. I'll just flip through and I'll stop. This is nice of the SMV. I'm sorry, that's the IVC. And there's the head of the pancreas. So this little bitty thing will be your portal vein. Now that remember, they're saying portal vein here. All these are little portal veins. Okay, you'll see them throughout. There's the pancreas tissue. So practice seeing it. There's that SMV with the neck and uncinate. Here it is here. So look for your vascular structure if you can't find the pancreas. There's your SMV. So here is the neck, and here is the uncinate. The aorta is going to be the body. There's your splenic artery and your splenic vein. So the splenic artery is more superior than that splenic vein. Okay. Here's this body. Here's that SMA, splenic artery, splenic vein. This is the tail. So now we're all the way left lateral of the aorta. So here's your spleen. And there is your tail. So use those vessels to guide you. Okay. Left lateral liver. Here's this tail. Splenic vein, splenic artery. Body, artery, vein, transverse. This is measuring the aorta. So aorta transverse mid. This is what we're learning in the very beginning, and your pancreas was there the whole time. So go back and look at it and see if you can pick it out. Another liver long, left lateral. Here's the pancreas. So it is just adjacent to that liver. Body with the caudate, pancreas. Here's that CBD elongated, okay? So this may have been in your gallbladder study, but here's that pancreas head right here. Pancreas head, here's that portal vein, IVC. Main pancreatic duct, duct of Wirsung. Here it is here. You got tissue on each side. This is not the CBD. You won't see the CBD in the middle of the body of the pancreas. You're only going to see the CBD in that posterior lateral neck. So here's a nice pancreas. Got some fluid in the stomach. It outlines the tail. We've got the CBD. I think we used this image before in the GDA. And then here, it's like there's a little bump here. What's going on here? This is the kind of thing you're going to have to get used to seeing normal outline. And this is a very bulbous tail area right here. And this could be a pancreatic pseudocyst. So these, you'll notice, there's the IVC, there's the aorta. What is this? So if you just take images of this long transverse, put some color on it, and then they will decide. Sometimes you even take cine clips to give them a little movie to get further information. Here's a pancreas. There's that liver. This is all stomach wall. Okay, and then we have this CT of the pancreas. It looks inflamed right here. Looks hypoechoic here. The end.